with this disease, our goals with treatment, and I have no doubt that pemetrexate and cisplatin help the patients, but our goals are prolongation of survival, pain control, and dyspnea control. And the published work on quality of life showed that they did have fatigue, so that's something we have to consider. And also, they showed that dyspnea was the main relief that the patients had, whereas pain relief was minimized with chemotherapy. So I think we have to consider a number of things when we have an individual patient. What is their goal? And we have shown that nearly everybody with pleural effusion gets relief from talc poudrage without chemotherapy. So focusing on survival and pain control should be major considerations or indications for chemotherapy. And I just wonder what your view of that, since many of the studies with chemotherapy don't do talc poudrage or pleurodesis first. Pleurodesis, talc poudrage, thoracoscopic talc poudrage, which is an outpatient procedure or inpatient for 3 days under local anesthesia.
So the question is, the question is how to deal with the symptoms or how to address them?
To choose the goals of the patient, whether it be survival, pain relief, or dyspnea relief.
Absolutely, and I think a lot of these decisions, are very individual per patient, and we have, in our experience, what we have noted is, I completely agree with you, is that pain control is a big problem for our patients. So we have a very active pain service that we are referring the patients to, and we concentrate on the pain control. But absolutely, all these symptoms are very important and are still problematic in addition to the progression-free survival and overall survival.
Thank you for Dr. Provo. My comment is that the Sloan Kettering study, 26 months survival with your treatment is very exciting. However, Valerie Russ 10 years ago published her stage 1 patients with 34 months survival. So I hope that you're planning a randomized controlled study to see what the true benefits will be.
Yes, the dollar value or the dollar expense of the different modalities?
The total expense?
Yeah. Any equivalent per month of survival?
Well, no, we haven't. We're just looking for something that's going to work first, and then we'll assess the cost. No, we haven't. It's not been looked at really carefully, no. But that certainly is going to be an issue eventually.
Medical question here. I guess I'm the non-medical person. How you all deal with clinical trials? How do you decide which person is going to go with the treatment that might work and the one that is not working or is not the one you're trying? Do you understand my question? So basically, you're giving one medicine that might work and the other one water that won't work. And so how do you decide which is the optional person?
Classically, it's supposed to be randomized. So it's supposed to be a random, most of these treatments, we actually don't know whether they're truly working. We don't know exactly if they'd work in any one individual. So the idea is if we randomize people to 2 different groups to get it or not to get it, then we can prove yes or no that it actually works.
Well, if you let us say you have a person that already has failed in whatever treatment they're in, I'm assuming you're not giving a clinical trial to someone who walks in and says, well, I've got meso, please give me a clinical trial. You give it to somebody that's either been not successfully treated or not, their body hasn't responded, or they are not a surgical patient or another patient. So how does somebody decide that this person is going to get nothing, which they've been getting, and so then they turn around and die, as opposed to a person that it might work? That's, I guess, kind of my question.
I think generally we all try to enroll people into clinical trials so we can learn something while we're doing treatments. And if there's a clinical trial for somebody and you qualify, then we try to put you into the clinical trial as appropriate. If you don't qualify for one reason or another for any of the clinical trials, then we treat people based on the best, guess in terms of what we can come up with something that's effective. So I think that would be the general approach.
I'd like to add something to that she probably doesn't know, is that there was a study 25 years ago or 30 years ago in England showing that patients who were felt to have no possible benefit from treatment, and they were followed with no treatment, and that 8% of them lived for 5 years. That's a study by Law et al. From the Brompton. So you don't know how the patient is going to do until you do the trial.
And again, with some of the data that I have shown, which were all negative data, but there is no recognized second-line therapy that truly works and that has been proven to improve survival. So that's some justification for clinical trials, that there is a proven therapy. Our goal is to do no harm. We would never put somebody on a trial if there was a therapy that worked and that we knew that would work.
In answer to the question of the individual on my right, if a study or studies do turn out to clearly show benefit, the study can be interrupted to include people who may not be getting the medication, and that is an option. Isn't that correct?
Yes, there are often scheduled data analysis time points where you look at the data, make sure that you can tell if something is actually showing benefit. You could stop the trial and then treat everybody with a beneficial treatment. So yes, those are usually built into it. I just have a question for Dr. Trovo. In your slides, you showed that the pneumonitis is a reasonable problem with the radiation, but did you have much esophagitis or other complications?
We had esophagitis grade 2, grade 1 and 2. I think all patients has because the esophagus very often is treated.
Yeah.
But we don't have grade 3 esophagitis.
Okay. And when you're drawing your lines, I noticed your treatment lines are a little bit farther away from the pleural edge than I would draw them. Have you thought about decreasing the amount?
Yes, exactly. We started keeping, because in radiation oncology, you have to keep a margin between the target and a safe margin. So actually the target is larger than it appears. And now we are decreasing the medial part of the target because we have now a new technology which is namely 4D CT, so we can account the motion of the lung, and so we can reduce the margin.
But this is from Dr. Trovo. So in your simultaneous integrated boost technique, 240 centigrade seems a little bit high to me. Do you target it to the gross residual tumor, or do you target it to the pre-op as well?
No, we don't target pre-op.
Okay.
No, it would be impossible, of course, yeah.
Dr. Olevsky, excellent overview of available options. I have one question regarding the TKIs and all the stuff that you mentioned are so far negative, but Sutent was reasonable to a certain degree, or
there
not?
was no survival difference.
No survival difference.
No difference in progression-free survival. None of them, actually.
On the same note, I was looking at a drug that is currently being used in sarcomas, which is the GSK drug Votrient or Pozatinib. Yeah. So I was just thinking about it as, since it's effective in sarcoma, how come this was not one of the studies?
There are no trials. You could start one. There is no
trials.
Not
and
yet.
so have you considered using it?
We have considered it. We have difficulty getting it approved, but we definitely we talk about it all the time.
We actually had one patient on it. We got on it, yeah.
And
actually, a Kaiser patient,
and
believe it or not.
Is that, I mean, one patient on it. So at this point, I mean, few weeks or?
No, she was on it for a couple of months, at least a couple of months or so.
And you know, regarding the desmoplastic variety of mesothelioma, I mean, have you seen patients with these entity responding to any treatment? And if they do progress, do they progress into a sarcomatoid kind of pattern, or do you have any comment?
We usually don't rebiopsy them, but with the biphasic mesothelioma and with the sarcomatoid, just generally, the trial after trial have shown that they do very poorly. And the only way that we have been able to approach it, and again, these are just anecdotal experience, that we have treated them as sarcomas, and we do the way we kind of decided is we say that if the majority of the tumor histology is sarcomatoid, we'll approach it as a sarcoma.
One last, do you have a bias in terms of what you're using up front, or do you really depend on presentation and, like, I mean, I know Alimta cis or carbo is the approved modality. I don't know, my experience has not been as good as it's reported compared to other agents.
For patients that have epithelioid histologies, we do use Alimta and cisplatin if we can. In patients that are not in great functional status, we use carboplatin. In patients that have sarcomatoid histology, we use a phosphomine and doxorubicin up front. If they fail, we use gemcitabine and taxotere.
There is interestingly one patient, again it's an anecdote, but that had induction therapy for a sarcomatoid tumor, and the tumor that we took out was almost all essentially a epithelioid tumor after we had treated the patient. So whether the biopsies were incorrect or whether there's actually a selection of the tumor type, we don't know, but that was an interesting finding on one of the patients.
Dr. Olevsky, what do you do for patients that have a 50-50 mixture of sarcomatoid and epithelioid?
We think about it, and then we treat them as sarcomatoid.
Say again?
We think about it a lot, and we toss a coin, but then we do think that the sarcomatoid component is probably more important in terms of distal spread, because what we have, and we do use chemotherapy for that, we have been incredibly successful with treating local recurrences with cryoablation, and I think you have seen the data. But so the distant spread is more of a problem, and we do treat them as sarcomatoid.
The number of patients that actually are in the 50-50 group is very small. So in the IMIG meeting, which happened last fall, Dr. Sugarbaker in Boston presented, their pathologist presented their information, and vast majority of people are either 70 to 80% of one or the other. And the number of people actually in the middle was very small. So it doesn't happen that often.
For people who've had a very good clinical response to cyst and pemetrexed regimens, what is your approach for possible maintenance regimens with pemetrexed alone? Or is that a possibility?
You address it.
We have been based on, and I think Dr. Cameron can address it more based on the experience that he's had, but we've been using interferon. And you can talk about the data.
Nobody knows what any maintenance therapy. Obviously, the lung cancer data suggests that maybe maintenance pemetrexed would be good. In patients that we've operated on who, have had basically good resections surgically and then had radiation postoperatively, which is our standard, we don't actually necessarily give them chemotherapy at that point, because as the extended access data shows that the actual response rates for most people in carbo Trovo or cis and pemetrexed is really in 20% to 30% range. So it's hard to give people that amount of chemotherapy for up to 6 cycles in a postoperative setting after they've been through surgery and radiation already, with only a small chance of any benefit. So often what we've done is put people on maintenance therapy based on, again, Judith Folkman's work with interferon and using low-dose continuous daily interferon, giving up to 2 million units per meter squared. And in those patients that again, this is just a cohort of patients that, you know, their median survival is basically approaching almost 5 years, but that's again a selected patient group. And then what we do is once somebody gets a recurrence in a localized area, then we can either do chemotherapy at that point because we can assess the responses, or do other localized therapy, which we have, which is cryoablation. So.
Sort of a corollary to this question, and in patients that weren't treated surgically, when is the right time to treat them that are not, that haven't had radiation or chemo? And there was this trial that looked at it that showed that we really should not be waiting for symptoms. We should treat patients sooner rather than later because there was an outcome difference.
This is a question coming from a pathologist, so you should question its utility. You know, because there's very little choice of therapies for the sarcomatoids, I wondered if anybody had tried using the agents that are active in gastrointestinal stromal tumors, the c-KIT biologic response modifiers, and if there have been any trials for patients with sarcomatoid.
Again, there definitely have been trials with the imatinib, you know, targeting the c-KIT, and those trials were negative. Patients were not stratified according to the histologies, but that has been looked at, and that data came from MD Anderson, and those were not. There was some response, but again, when the data was analyzed, there was no difference.
Lunch is available in the next room, so we can adjourn to the